last speaker is Dr. Aryeh Fischer, who is a rheumatologist at the University of Colorado. Dr. Fischer is going to talk to us about autoimmune mechanisms in pulmonary fibrosis and related connective tissue disease-related ILDs. Aryeh?
Thank you, Dave.
Yeah.
Thank you very much. It's a great honor to be here. It's really wonderful to see the growth of the Pulmonary Fibrosis Foundation and this summit. Thinking back, I think the first summit in 2011 in Chicago, much smaller venue, much smaller audience, and now here we are filling up ballrooms and overflow. So kudos to the organization. Thank you to the organizers for this opportunity. And as a rheumatologist, I feel especially welcomed by the interstitial lung disease community. I think initially when I used to come to ATS and PFF chest, it was really to take care of gout in the older ILD doctors that would get acute exacerbations during various nocturnal activities. But, as things have progressed, I've really been, I think, welcomed as a rheumatologist engaged in this domain. And I joke with Ganesh, who acts really as a rheumatologist in many ways in his practice, and in some ways I pretend to act as a pulmonologist in mine. So I do think that we have a real interest in this shared entity of autoimmune ILD. My disclosures are not relevant to the content of this talk. But really the issue or the diseases I'm here to discuss are diverse. We call them connective tissue disease, but they really are a spectrum of autoimmune diseases with quite often systemic features, autoantibodies, organ-mediated or autoimmune-mediated organ damage, and truly heterogeneous, really not just one disease. And so the connective tissue disease spectrum really should be highlighted by its diversity and heterogeneity, and this is the list as we really think of autoimmune diseases that are systemic that impact with interstitial lung disease. We tend not to put vasculitis in this group, but I think we all really struggle with this question. Why is it that we see so much interstitial lung disease and systemic sclerosis and so little in systemic lupus? What is it about these individual diseases that intersect with ILD in unique ways? And highlighting the heterogeneity in the connective tissue disease spectrum, I think, should also be mirrored by the heterogeneity in the lung injury patterns that we can see in these patients. So we can see patients that have systemic sclerosis-related NSIP, we can see rheumatoid with organizing pneumonia, we can see Sjogren's with lymphocytic interstitial pneumonia, and understanding why those patterns tend to exist, I think, remains challenging and in some ways unanswered. So when I was looking at sort of the agenda and what I'm asked to talk about, its mechanisms, its this whole spectrum of connective tissue disease, which ones would be perhaps worth focusing on? Looking at my clinic in Denver, we published this abstract at ATS last year where we looked at the cohort of our patients with autoimmune ILD and what diseases they had. So scleroderma stood out as the most common. We saw a lot of patients that look autoimmune but don't fit criteria per se. They have interstitial pneumonia with an autoimmune flavor or IPAF, rheumatoid and myositis, and surprisingly little lupus and not as much Sjogren's. So trying to maybe ask questions about at least the three big groups, scleroderma, rheumatoid, myositis, and maybe just a comment at the end about how we define autoimmunity. So when I think about systemic sclerosis and autoimmunity, I find it striking that autoantibodies can really help with regards to predicting organ involvement. This is certainly not a perfect arrow, diagram whereby there are no exceptions, but by and large, we appreciate that patients who have systemic sclerosis with an SCL70 antibody, or patients that have the THTO U3-RNP or even the UL-U12-RNP antibodies, have a very strong risk for progressive ILD. And yet when we see centromere antibody positive patients, we recognize they're at higher risk for PAH, and then an RNA polymerase III antibody for renal crisis. When we talk about dermato and polymyositis, we recognize that interstitial lung disease is the most common lung manifestation, chief cause of mortality, and yet these patients can have varied clinical features. They may or may not have muscle disease. We see a lot of NSIP with organizing pneumonia in these patients, but you can see other patterns. And we talk a lot about the anti-synthetase syndrome. And thinking about this syndrome and the synthetase panel of antibodies, the most common being Jo-1, but we know that there are 7 other, at least at this point, recognized synthetase antibodies. We appreciate that this is perhaps a very classic autoimmune-mediated interstitial lung disease. Some would argue that's exactly what it is. It is an interstitial lung disease, perhaps more than it is a myositis. And clinical features that we often see, but don't always see, include muscle inflammation, include interstitial lung disease, include Raynaud's phenomenon, mechanic hands. Another immune-mediated or autoimmune antibody that has been identified and closely linked to interstitial lung disease, perhaps a cousin to the synthetase spectrum, is the MDA5 antibody. And the MDA5 antibody describes a clinical phenotype at this point, which is clinically amyopathic, no muscle inflammation, deep cutaneous ulcerations, very characteristic fulminant presentation with life-threatening diffuse alveolar damage. Initially, those were all the reports, and now we're appreciating that there's more of a spectrum of MDA5 with NSIP, organizing pneumonia as well. And I think this story and the discovery of more synthetase antibodies highlights just that, the role of discovery in these quote-unquote idiopathic interstitial pneumonias that are now all of a sudden autoimmune. And it's not just about the myositis, right? As a rheumatologist, we see lots of myositis patients. But if you look at the spectrum of myositis that we see, well, which are the ones that are associated with ILD? The synthetase, the MDA5 story, polydermatomyositis, and myositis with other connective tissue disease, like an overlap form, lupus with myositis, scleroderma with myositis. But look to the side of the right. We see inclusion body myositis without interstitial lung disease. It's essentially a case report if you see it. Myositis with statins, another immune-mediated myopathy without interstitial lung disease, and myositis associated with malignancy associated with a different antibody, TIF1 gamma. And in juvenile dermatomyositis, not much interstitial lung disease. The antibody profile in these myositis patients, I think, highlights sort of the underpinnings of autoimmunity. And if you look at this, I think really beautiful picture that can be a little bit confusing. The arrows meant to highlight where interstitial lung disease intersects, perhaps. So we see the anti-synthetase family of autoantibodies, and that list is going to grow as more synthetase antibodies are discovered in this scenario. We have the MDA5 story, that CADM, clinical amyopathic dermatomyositis with rapidly progressive ILD. And we have overlap forms with PMSCL or U1RNP, the mixed connective tissue disease patient. And yet if you look at the ones that are not associated with ILD, why is that? Why is MI2 dermatomyositis with cardiac involvement? Ingrid Lundberg from the Karolinska Institute in Sweden came to the University of Colorado just a few weeks ago, and she shared this slide with us, really posing the question as a rheumatologist and a translational scientist, does myositis start in the lungs? And she highlighted several important papers that have posed that question. So it's interesting when you look at what Jo-1 does. So Jo-1, one of the synthetase antibodies, is predominantly expressed in the lung. It is seen in the muscles, but it's predominantly expressed in the lung. And when it's cleaved by this protease, granzyme B, that cleavage exposes new epitopes. And if you look at what those epitopes then do, they spread and interact in the immune system with important chemokines, attracting these immune receptor cells, the CCR5. And so you kind of wonder, well, you just described these synthetase syndrome patients who don't necessarily get muscle disease. Maybe this is a good example of where an autoimmune disease that starts in the lungs may or may not have systemic features. And building on that story about whether some of our systemic autoimmune diseases start in the lungs, we'll get to that at the end with the comments on rheumatoid. But we know that rheumatoid, perhaps the next frontier in this arena, primarily because we see so much rheumatoid in rheumatology clinics, 1% of the adult population with rheumatoid arthritis. And there's a growing appreciation that interstitial lung disease and lung disease in general is super common in rheumatoid, and it really just depends on how hard you want to look for it. But it also comes in a variety of forms, subclinical, mild, more severe. And it's important from the standpoint of our patients' long-term survival, a driver of RA-associated deaths in many cases, and the risk of death with RA-ILD quite significant, threefold risk for a rheumatoid patient with ILD compared to without. And this is a really nice picture from a very, I think, important perspective written by Hal Collard and Talmadge and Eunice Kim from UCSF a few years ago now, where they highlighted the disproportionate representation of UIP in rheumatoid patients. And if you look at rheumatoid compared to the other connective tissue diseases, the UIP pattern, the usual interstitial pneumonia pattern that we see in idiopathic pulmonary fibrosis, is overrepresented relative to the other connective tissue diseases, where you tend to see more of an NSIP predominance. And as that story is building, the survival of rheumatoid with usual interstitial pneumonia perhaps more closely mirrors that of idiopathic pulmonary fibrosis than any other connective tissue disease-related ILD. And in this study out of South Korea, with small numbers that are worthy of being careful to not make firm conclusions, but if you look at the CTD-UIP population in general, they tend to do better than idiopathic UIP, than IPF. But the rheumatoid UIP survival tends to be closer to IPF than the other connective tissue disease ILDs. And similarly, out of a Japanese cohort, highlighting that in rheumatoid, the finding of UIP tends to be associated with a worse survival experience than rheumatoid with NSIP. Again, small numbers, but a similar story being told in different cohorts from around the world. Josh Solomon from National Jewish published this paper looking at fibrosis as a risk factor for survival. And so the presence of fibrosis being a driver of mortality in rheumatoid in addition to older age. In a nice review of predicting mortality in RA-ILD, Deba Sayag and her colleagues at UCSF put together, I think, a framework that's helpful practically as a clinician, and I think asks questions from a scientific perspective as well. If you look at what predicts mortality in RA-ILD, it looks a lot like the story of idiopathic pulmonary fibrosis. Older patients, male patients, patients with worse physiologic impairment, fibrosis by CT, fibrosis on a biopsy, a UIP pattern. And in fact, many are asking, is rheumatoid UIP the closest disease that we have to idiopathic UIP of the connective tissue disease spectrum? Is it IPF in an RA patient? I think those are questions that are still unanswered. And the CCP, the anti-citrullonated peptide story, is at least worth mentioning. This is a study out of Johns Hopkins that looked at CCP and a broad array of these anti-citrullonated peptide antibodies and whether or not they impacted or predicted lung involvement. And so I tried to highlight these figures with boxes to get your attention. So on the top upper left, B, the high CCP, high ACPAs were associated with more extent of ILD, a higher ILD score. The figure C demonstrating more reticulation, more fibrosis, more honeycombing. The image D demonstrating more ground glass opacities, and then finally, more physiologic restriction. In a smaller study, in a single center, a novel autoantigen perhaps for rheumatoid ILD, HSP90, heat shock protein 90. Patients with rheumatoid ILD had higher levels of HSP90. Hasn't, to my knowledge, been replicated, but just another area, I think, ripe for discovery. Leading to this notion that we have risk factors for rheumatoid ILD. Being a male, being older, not sure what that age cutoff is, cigarette smoking, having the genetic locus for rheumatoid, shared epitope, high titer rheumatoid factor, ACPAs, citrullonated HSP90, at least from one study, maybe more severe articular disease, but I don't think anyone's convinced that the joints and the lungs have much to do with each other in this illness. And then recent data from Joyce Lee and others demonstrating MUC5B mutation, just like in IPF patients, again, highlighting the similarities perhaps between rheumatoid UIP and IPF. And I'll tell you, when I show this slide of risk factors to my rheumatology colleagues, they say that's their whole Wednesday clinic, right? That's what rheumatologists see, and yet, are they missing all of this ILD, or is the truth somewhere in between? And similar to the question about myositis, there's a growing appreciation, or at least interest. Hey, does rheumatoid start in the lungs? Well, we know that cigarette smoking is a potent risk factor for the development of rheumatoid. We know that there are increased citrullinated peptides in the lung tissue of smokers. We know that we see lots of CCP antibodies in rheumatoid arthritis. Smokers with this shared epitope may have this initiation of autoimmunity in their lungs with citrullination of peptides, leading to CCP-positive rheumatoid. And there's this notion that there's higher CCP prevalence in rheumatoid with lung involvement. We looked at our cohort at National Jewish a few years ago of patients who had a CCP drawn without clinical features of rheumatoid from an articular perspective. So in some cases, we couldn't tell you why the CCP was sent. Asthma, COPD, unexplained breathlessness, unexplained ILD. But the message being that none of these patients had rheumatoid. They all had a quote-unquote highly specific autoantibody for rheumatoid. And if you look at their phenotype from a pulmonary perspective, we identified patients that had isolated airways disease with parenchymal lung disease, parenchymal lung disease alone, combined pulmonary fibrosis with emphysema, and some of the phenotypic aspects of their lung morphology reflected, or at least got the pathologist or radiologist thinking, yeah, this could be rheumatoid lung involvement. And a small subset went on to articular RA, but most didn't. Borrowing this slide from my colleague at the University of Colorado, Kristen Demerel, she and Kevin Dean and Mike Holers have really pioneered a lot of this work in terms of, does the lung represent the initiation of RA? Apologies. Can I go back one? So she asks, well, maybe first phase we have a genetic risk with some environmental exposure, cigarette smoking, for example. We have citrullination in the lungs, followed up by clinical lung disease, and ultimately the final phase from a rheumatology perspective is the development of inflammatory arthritis that we can then classify as RA. And then schematically, showing really that same story, we have the lungs and some interaction between the environment and the lung mucosa and the immune system. We see generation of lung inflammation in the lungs with local generation of RA-specific autoantibodies, and then detection thereafter of circulating RA-related autoimmunity. So in the lungs initially, perhaps in lymphoid tissue, in the mucosa, followed by circulating serologic antibodies, and then perhaps clinically bringing it all together, inflammatory arthritis. And then I'll leave you with this. just to pose the question of what we label as autoimmune, I think, is sometimes, maybe it's a little bit arbitrary, maybe it's center dependent, maybe it depends on who you ask. So does this patient here have an autoimmune interstitial lung disease? A 67-year-old woman with shortness of breath, a CT that is read at our center as possible usual interstitial pneumonia, with long-standing, unimpressive Raynaud's phenomenon, a negative ANA, but a positive SSA, and then a biopsy that shows lymphoid aggregates. We've posed this question to a number of leaders, clinicians, and we'll hear IPF from a handful. We'll hear this is Sjogren's from another. We'll hear this is definitely interstitial pneumonia with autoimmune features. And I think that this just highlights that what we call autoimmune ILD is sometimes unclear. So my summary, and just a brief point about systemic sclerosis, how interesting it is that autoantibodies, more than skin, can predict lung phenotype and often organ involvement in general. For anti-synthetase in the MDA5 story, there'll be more synthetases to be discovered. This is probably one of our more classic autoimmune-mediated interstitial lung disease, and I think it's fascinating to ask and study, does myositis, whatever we should call that systemic autoimmune disease, start in the lungs? For rheumatoid, I didn't go into this, but certainly Dave and others have highlighted how important it is to look for ILD in RA, and there's a lot of subclinical disease. We know that fibrosis portends poor prognosis, lots of similarities to IPF. I've highlighted the, I think, important questions. Hey, does rheumatoid start in the lungs? And finally, this concept that we see a lot of ILD patients, interstitial pneumonia patients, that look autoimmune, and sometimes the autoimmunity definition is unclear. Thank you again for the honor and opportunity.